Hey guys, welcome to the PACU. Today I'm going to be talking about calcium and its use in hyperkalemia. So a mnemonic I like to use when discussing the treatment of hyperkalemia is cigar loops. And the components of the cigar loops are going to be calcium salts, insulin, glucose, albuterol, resins, which are going to include K-oxalate and Lokelma, loop diuretics, and sodium bicarbonate. But let's discuss more in particular the calcium salts today. So before we move into that, we first have to understand hyperkalemia's pathophysiology. And one of the key things we need to look at is the fact that hyperkalemia is going to lead to a less negative resting membrane potential. And this places it closer to this threshold potential. So these are a lot closer now compared to when it was at negative 90. This is becoming a lot closer, and that's going to impact a few things. So just to recap, we know that it's going to lead to this being here, your resting potential being up, and that's going to lead to you potentially having some issues as well with your sodium channels. And in particular, resting membrane potential, as it increases, the sodium channel, in particular, the NAV 1.5 activity begins to decrease, and that's going to lead to a decrease in your VMAX here. So another way to look at this is the fact that as you have a VMAX of 300, which is the max, that's going to be here at negative 90. But as you move to a less and less negative, you start to see that decrease in that VMAX. And we can see this as we see this move slowly and slowly this way compared to it moving straight up and having a really strong VMAX at about 300 millivolts. The next component is, how does calcium work? And this is a pretty interesting study, and definitely a big shout out to Tony Brew, who made this component and brought this to our attention. In low calcium settings, it's going to take a fewer number of depolarizations to get an impact, compared to in a high calcium setting, it's going to take multiple and a larger number of depolarizations to see an impact. So what the authors concluded in this study was more depolarization was required in calcium-rich solutions, and the resting potential was unchanged, but the threshold potential had increased. So this is going to be one of the ways that calcium can impact the threshold potential. Another way that calcium impacts hyperkalemia is through the actual sodium channel itself. So traditionally, the sodium channel is going to be blocked off by the fact that you have that increase in the resting potential. And one of the ways that calcium can combat that is through its use here. And we see that it's actually going to restore channel activity through calcium-dependent calciumogene, and that's going to recruit voltage-gated channels here at the NAV 1.5. And ultimately, that's going to lead to an increase in intracellular sodium entrance, and that's going to restore your VMAX at that phase 0 and cause you to have a really rapid action potential. So let's look at this in a different way. Without calcium, you're going to look here, you're going to see a low amount of sodium entering the cell, and you're going to see that VMAX here being decreased compared to usual, and that's going to ultimately lead to an increase in your QRS interval. Compare that to when you actually have calcium, you're going to see you're going to have a large amount of sodium entering that cell, and that VMAX is going to be really rapid. And as we see here, we're going to see a decrease in the QRS interval. So let's move forward and think about, is there any data to compound this? Because a lot of it is just expert opinion, but where do we get this information to start from? So when looking at this study done by Winkler and colleagues, they were one of the first to display that calcium chloride is effective at protecting the heart against otherwise fatal concentrations of serum potassium. And what they did was give many concentrations of either potassium chloride by itself or potassium chloride in combination with calcium chloride. So you had those two combinations, and what they found was that those patients that had potassium by themselves, as indicated by the clear box here, they died at much lower serum potassium concentrations compared to those patients that had a potassium and calcium mixture. They tolerated much higher levels of serum potassium before having mortality. So again, this is another impact of calcium, just being able to show that it is protective in this standpoint. There's a few other studies that looked at this, and most of them are case reports. The data is not really strong when looking at this, but in 1950, American colleagues found a beneficial effect of IV calcium salts in 9 of 10 of their patients. And after that, a few years later, Chamberlain and colleagues reported 5 cases of immediate impact of calcium on EKG changes induced by severe hyperkalemia, with ranges anywhere from 8 to 10 millimoles per liter. And in a study in 1954, Maroney and colleagues found a beneficial effect of intravenous calcium salts in 46 trauma patients with hyperkalemia. And as we can see here, this is the initial very wide QRS. After about 37 minutes with close to 3 grams of calcium gluconate, you start to see improvements in that EKG compared to the baseline. Another one we'll see here in another patient, you didn't see a much improved EKG as far as closing of that QRS interval here. And when combining calcium chloride and sodium chloride, you again see a very beneficial impact on the EKG changes, and this is almost close to normal at 30 minutes. However, the authors concluded that it produces a striking improvement in the electrocardiogram, and this improvement was transient. So again, they only expect this to occur for anywhere from 30 to 60 minutes. So overall, just kind of wrapping ourselves around calcium salts, we know the indications for EKG changes by itself. The dose is going to be anywhere from 1 to 3 grams of calcium gluconate or 1 gram of calcium chloride. The onset is going to be rather immediate with less than 5 minutes, and duration ranging anywhere from 30 to 60 minutes. Some key things to look out for is the different formulations that we have, and depending on that, you will have access to it at your institution, whether it's going to be in the code card or in your automatic dispense cabinet. Calcium gluconate is going to be great for peripheral IV administration, and it's going to have about 4.65 milliequivalents of elemental calcium. And compare that to calcium chloride, which is an extravasation risk for peripheral IV use, and it's going to have about 3 times the amount of elemental calcium. So thank you guys for listening to this video.